So do caffeine clots need to be anticoagulated? That's a question. And this is a messy topic, so I'm going to try to structure it and organize it. First, we're going to go through the history of the thrombus, and then we're going to bring in the data points from, gosh, starting in the 70s up to current, so that you can kind of see where we've gone and why the recommendations are what they are. And so I know most of you, like when we do an ultrasound on a new patient, my techs will come to me and say, there's an old gas clot. And I'll ask the patient, they have no idea. And so the reason this is messy to start with is that most of these isolated caffeine thrombuses are asymptomatic. And so we don't really know how to capture all those people to say how many of them are dangerous. We assume that most clots start in the calf and that they're asymptomatic, and then as they propagate and become more proximal, the symptoms increase. And so 90% of the time when there's a proximal clot, it's associated with the caffeine, and we think that that's the trajectory, and that growth phase is over the first week, 90% of the time, but maybe up to 2 weeks. And that's where this 2-week recommendation comes in, is that growth phase. And we know all the information about PE, DVT, the trajectory is much worse than it is with isolated caffeine thrombosis. And so all of us agree that we should treat DVT and PE if it's proximal. There's just no question about the benefits of that. And in 2020, the American Society of Hematology released their updated guidelines. 21, the chest physicians released their guidelines, and they really started to break it down for us a little differently, where you get the diagnosis of DVT, and then you have an initial management phase, okay, which is like when you do the BID dosing of Xarelto or the 10 milligram dosing of Eliquis. Then you go into a management phase. The American College of Chest Physicians says 3 months is adequate. The Hematology Society kind of says 3 to 6. Everybody agrees that after 6, there's no need to continue. But at that end of that treatment phase, there's a second decision. And that second decision is going to be, what do I do to prevent recurrence? Okay, so that's our standard. And remember, the goal of treatment is always to reduce the morbidity and mortality associated with VTE, right? So if I tell you that an isolated caffeine clot doesn't have any of those problems, why are we treating it? So the tenets that I'm going to break this into is pulmonary embolus. We're going to look at recurrence. We're going to look at post-thrombotic syndrome, and we're going to look at propagation by itself. Because if that isolated caffeine clot propagates, it falls into another risk category. And remember, people that die of pulmonary embolus, they do it right away, right? It's acute. So 10% of those people will die within the first hour of that diagnosis. And that's what makes this so critical. So the risk of propagation is assumed to be somewhere between 8 and 25% of the time. In propagation, we think of it as going into a proximal vein, but it doesn't have to do that. It can go into another calf vein. And so I borrowed this slide from Dr. Masuda's paper here, and it looks at if the clots were to propagate, where do they go? And 8% of the time, they're going to go into an adjacent vein. Okay, and that becomes important here in a minute. Schwartz was the first person in 2010 to say, hey, let's just try to randomize people to low molecular weight heparin for 10 days during that growth phase versus surveillance. And what happens? And he found that there was really no change in the propagation, whether they got the low molecular weight heparin for that 10 days or they didn't. And he started to define this low risk patient population. And so you'll see, we'll expand on that in a minute. And when we talk about caffeine propagation, if Ferreira did this study and he looked at 6 weeks versus 12 weeks, but what was interesting of this study is that if there were 2 or more caffeines involved, they behaved much worse than if there was just an isolated caffeine thrombosis. So if you're looking at it as an isolated caffeine thrombosis, it shouldn't involve 2 branches or 2 different veins. So the risk of propagation depends on why did this happen in the first place? And multiple studies have looked at the role of malignancy, and several studies look at the role of malignancy, and we'll go through that over and over and over again. And so that should be in your mind if you see one of these clots. But then they also started to define these transient risk factors like travel, hospitalization, recent surgery. And the REAT study was really nice because it has this humongous database, right? And it looked at the people that presented with proximal clot. They were elderly, they had bleeding risk, they had a history, they had cancer, they were complicated. But the people that had isolated caffeine clots, it was a transient risk factor. It was travel. It was a recent hospitalization, varicose veins. Those people didn't tend to present with an extensive clot from varicose veins. There were also studies looking at idiopathic, like, well, we don't even know why this happened. We worry a lot more about those people. And there was a trial that specifically looked at that and isolated that patient population. And then if you have a bilateral DVT, now if I see an isolated caffeine thrombosis, I am not scanning the other leg present time, right? So, but if you have a bilateral DVT, The mortality goes up to 17.5% with those people. And so that's something to consider too. And those bilateral DVTs, again, are going to be associated with malignancy often. Other things have looked at the diameter of the thrombus and thrombophilic states. So what? So if they have a calf vein clot and it just stays there, so what? Well, if it does propagate, if it does make its move, you have to look at what is the risk then for these patients of pulmonary embolus. And about 40 to 50% of patients who present with a symptomatic blood clot already have a pulmonary embolus. Now, that scares me, but we're treating them the same. We have lots of data points that say that doesn't matter. We can treat them as outpatients. So we're putting them on anticoagulation, right? Parch looked at 1,300 patients and found like the higher the clot, the more likely you are to have that thing go to the lung, and found that 35% of lower leg DVTs were associated with PEs. Kistner went a next level on this and looked at 54% of patients, or 54 patients, excuse me, with tibial or popliteal clots, found that 50% of those patients had a PE at the time of presentation. So 60% of those patients were popliteal, but still 33 in the tibial vein presented with a concurrent pulmonary embolus. And bilateral DVT, again, was associated with a 75% risk of PE. And again, we're not always looking for that bilaterality in these patients. So this was an interesting study too. Sorry, my slide looks a little different than when I put it together, but they divided unilateral distal DVT with bilateral distal DVT and unilateral proximal DVT with bilateral proximal DVT. But look what stands out here. If you have a bilateral distal DVT, your risk of malignancy is greater than any of those subgroups. So that to me really stood out too. But what about if I have isolated calf vein thrombosis? How do I watch these people? So there were 13 studies that looked at that specifically. I quoted 3 of them because they're the best ones out there. But Hall took 32 patients. Mind you, all of his patients were anticoagulated, and he did VQ scans at 2 and 6 weeks and found 0 PEs. Now, again, if you're going to get a PE, you're supposed to get it within the first 10 days of the presentation. That's kind of the timeline. Bentley looked at 32 patients, changed his surveillance to day 1 and day 7, found a 6.2% incidence of PE. In part, also anticoagulated all his patients, looked at days 1 and 10 and found a 3.5% incidence of PE. And again, I say to you, like, who cares? They're anticoagulated. If they're anticoagulated, then we feel comfortable. It's the group that we're going to choose not to anticoagulate that we need to be concerned about. So then what do we do with that? I mean, what does anticoagulation have to do with this? And so this was the follow-up to the Cactus trial where they said, all right, let's look at that 252 patient population. Let's see if the patients that got Lovenox did better than the patients that didn't. And so they were able to follow 178 patients through. The median follow-up was 6 years. They found no difference in the post-thrombotic risk, whether those patients got the anticoagulation for 6 weeks or whether they did not. They did show a higher risk of post-thrombotic syndrome, which was about 30%, but when they subtracted out the people that had concurrent venous insufficiency, it started to mimic the TULIP trial, so about 15-16%. And what was clear then, though, is that the recurrence rate was much better or much less if patients had been treated with low molecular weight heparin. So what about this recurrence thing then? We think that the recurrence is reduced with anticoagulation. And so when we're talking about recurrence, you got to look at short-term recurrence and long-term recurrence. So Hall, way back in 97 here said, there was really no difference in the recurrence rate for calf vein thrombosis. In 85, another study was done and it randomized people to get heparin plus Coumadin or heparin and nothing after the 5 days. And the recurrence rate was like 30% at 90 days. If they in the non-treatment group. So more studies keep coming, and some studies were looking at, well, is 6 weeks enough? I mean, maybe we can treat them for a shorter duration. And they found in the Cochrane review, which looked at 700 patients, right, randomized control trials, and it found that if they were treated with 6 weeks, the recurrence was definitely higher than if they were treated for 3 months. And so this idea of, well, could we just treat them for a shorter duration, didn't really bear any fruit. And there was really no change in the bleeding rates if you treated them for 6 weeks or 3 months. And what's interesting, again, with all this information, the REIT registry is from the 2000s, right? And these studies are pretty old. If you look at the observation of how people are acting and what are we doing in real practice, because that's what the REIT registry did, right? It goes back and it looks at what were the practice patterns. It didn't influence the practice patterns, but reviewed them. And about 90% of the patients with an isolated caffeine clot in this registry were anticoagulated, and the recurrence risk was 1.9%. So then you got to think about long-term risk, and as we talked about earlier, there's the initial management phase, but then there's that second decision, like what do I do long-term for these people? And it really, I think, goes back to what are your risk factors? And so when you're making a second decision for this patient about long-term risk reduction, I think you have to go back and say, what about these transient risk factors, major and minor? And this all came into the CHEST guidelines that were just republished in 2021 to kind of look like, well, if it was provoked by surgery, your risk after the first year is 1%. But if it was provoked by a non-surgical factor, it's 5%. And if there's an ongoing malignancy, it's a 15% recurrence rate. And so when I'm looking at what do I do with the long-term treatment of these patients, I'm kind of thinking a lot more than I'm just applying a protocol. I'm trying to figure out like what's going on in this patient. And it is appropriate to call your primary care doctor and say, we need appropriate age cancer screenings on these patients when we're seeing these isolated caffeine clots. So I apologize, it's not CVT, it's DVT, but this is the algorithm now. So if you have an isolated caffeine clot and it's asymptomatic, and then you have to go through your risk factor stratifications, and there are no risk factors, okay? You can do serial ultrasounds for 2 weeks to follow them during that propagation period. That means once a week, unless they become symptomatic, you'd have to bring them back and scan them again. And if there's propagation, whether it be into a proximal vein or into an adjacent vein, they need to be anticoagulated. If there's no propagation, they can be observed. So in conclusion, whether or not to treat these remains controversial. I think it's hard for us to isolate the data because we don't know how many people have asymptomatic clots that just go on their way and are fine. So we're starting from the wrong number of patients to track. And the recommendations today are really driving us as providers to think. I don't think there's a perfect answer for everybody. And remember, none of these studies were done with DOACs. These were all done in the warfarin, low molecular weight, heparin groups. So the Garfield trial, which this is their website, it kind of shows all the branches of the tree and how many patients that they've achieved, and they're looking at follow-up. So there's going to be really exciting information to come from that. And even just the observation of what people's practice patterns are changing too. And the last thing I want to say is we don't really have a standardized agreeable model to really balance out that bleed risk versus clot risk. There are some studies that say, if you have this many risk factors, your bleed risk is this, but I've never seen anything that's been completely formalized where we can say your clot risk is this, your bleed risk is this, let's make that best decision. So more to come.
Thank you very much, Dr. Kelsey, for that very comprehensive review. Seems like there's still a lot of work to be done, right?
Yeah.
Well said. Now, continuing on in this venous thromboembolic events session for this afternoon, we're going to switch the pendulum and go the opposite direction and talk about updates on treatment and management of massive and submassive pulmonary emboli. And for that, we have the distinct pleasure of having Dr. Efthymios, Makis, Avgerinos joining us remotely and virtually. He is the professor of surgery at the University of Pittsburgh, but also does a lot of wonderful work overseas at the University of Athens. So welcome, Makis, to the Vision Symposium.
Thank you very much. And I'm so unfortunate I cannot be there in person since the dates have changed. Peter, thank you for the kind invitation. Hopefully I can make it next time. So can you all hear me well as I'm remotely?
Yes.
Wonderful. So I will be presenting an update on the current management, contemporary management of pulmonary embolism. These are my disclosures. But before I start presenting all these fancy procedures we are doing today, I have to agree with Dr. Vedantam that any catheter-based therapy should not be called effective because absent the randomized comparison with a non-intervened control group, there is no way to know if patient changes over time were not simply due to the use of anticoagulation. We do not have good data that these procedures that I will be presenting and we're doing today are better than anticoagulation alone. And to have a strategy in the management of pulmonary embolism, we need to all agree on the basics. And the classification of pulmonary embolism is low risk when we have no right ventricular dysfunction, intermediate risk when we have positive echocardiographic markers of right ventricular dysfunction or biomarkers. And when in addition we have hypotension or need for vasopressors, then we name it massive or high risk PE. And anticoagulation is the standard of care for all these patients, but as the severity increases, we need to escalate treatment. And escalation of treatment can be systemic thrombolysis, catheter thrombolysis, aspiration thrombectomy, and surgical thrombectomy. And of course, this is a very difficult decision. Evidence is weak, low-level recommendations, high expertise required, high risks involved. And the foundation of today's practice goes back in 2014 when the PYTHO trial was published, and then a large systematic review indicated that systemic thrombolysis against anticoagulation is associated with the 47% mortality risk reduction. But this came at the cost, high major bleeding rates, 9%, including 1.5% risk of stroke. At the same time, more than 60% of the patients will actually have a contraindication to receive systemic thrombolytics. And around the same time, the ULTIMA trial was published, indicated that in intermediate risk pulmonary embolism, ultrasound-assisted catheter thrombolysis is superior to heparin alone in reversing RV dysfunction at 24 hours without an increase in bleeding events. In simple words, with catheter thrombolysis, you can achieve the benefits of systemic thrombolysis without the associated adverse events. And at the same time, there is some evidence that you can actually decrease the likelihood of long-term PE syndrome. And since then, we have seen a really big change in research for pulmonary embolism and catheter interventions. If you go on PubMed and look at the publications, we are seeing a geometric increase over the years in the investigation of these catheter interventions. In today's practice, we follow this algorithm for the use of catheter interventions that is the PERT consortium algorithm. In low risk and intermediate low risk pulmonary embolism, we're not going to intervene, anticoagulation only. But when you have intermediate high risk pulmonary embolism, that is positive biomarkers and positive echocardiographic markers of right ventricular dysfunction, we are going to consider intervention for the patients who have a softer blood pressure, who have increasing oxygen requirements, or a heart rate more than 110. These are the patients we're going to consider catheter thrombolysis if they're low bleeding risk, or aspiration thrombectomy if they're higher bleeding risk. And for the massive PE, high-risk pulmonary embolism population, we can consider systemic thrombolytics when we have no time to get into the operating room, or catheter thrombolytics when the patient can likely wait, or aspiration thrombectomy when the patient is crashing. Or we can just consider aspiration thrombectomy for everyone. And this is a discussion we can probably do afterwards. This is the hybrid operating room. We are performing these procedures. I will typically access the internal jugular vein or the common femoral vein. I will introduce a pigtail in the main pulmonary artery, and then I can initiate a thrombolytic or a non-thrombolytic technique. And thrombolytic techniques are the standard catheter thrombolysis, the ultrasound-assisted thrombolysis, and the recent addition of the Bas-Hier endovascular catheter. These are generally smaller and cheaper devices. Lytics can clear the clot in the remote pulmonary arterial branches. They are friendly crossing the heart, and we have a lot of evidence, but they prolong the procedure. There is still risk of bleeding, and there are frequent contraindications. This is the way we typically do catheter thrombolysis, introducing this catheter into the clot and infusing TPA 1 milligram per hour. We used to do 8 to 12 hour protocols. Now we are down to 6 to 8 hours. Ultrasound-assisted thrombolysis, the ECOS catheter, is technically similar to standard catheter dripping, but the addition of ultrasound, at least in vitro, seems to increase thrombus clearance by 50%. Well, this was not actually shown in the randomized trial we performed a few years ago, and it was just published. Thrombus reduction was similar irrespective of the use of ultrasound. Both groups within 48 hours showed a 20 to 22% reduction in thrombus. And this is the vascular endovascular catheter. The PE rescue trial is currently enrolling patients. You can see there are multiple wires dripping TPA with the potential advantage of reducing dripping time or TPA dose. And moving on to aspiration thrombectomy devices, we have so many devices currently available that macerate the clot and aspirate it. There is minimal bleeding risk, no real contraindications. You can achieve quick reperfusion, but these are expensive, large devices, difficult to navigate. There is a risk of heart valve and lung injury. There is a risk of decompensation, and there is still a risk of blood loss. Since you are not only aspirating clot, you are also aspirating blood. And this is the Penumbra device. We have been using it for the past 5 years, the CAT8 catheter with a powerful aspiration pump. And more recently, we got in our hands the CAT12 Lightning device, much bigger, can aspirate clot more effectively, and the Lightning component will reduce blood loss as it can differentiate clot from blood and stop when there is blood. The float reverse, here is actually a case. You can see me working through the neck, introducing the CAT8 catheter in the left main pulmonary artery where it is completely occluded, and following aspiration, we have a full recovery of the left lower pulmonary artery and an immediate improvement on the table with the heart rate dropping from 115 down to 80. The float river device now dominating the field. It's a standalone device, no capital equipment required. The float river sheath, 20 or 24 French, the float river discs, and the aspiration syringe. It mainly works with aspiration, but when you have more chronic clot, you can use the float river discs. Here is a case with clot on the right pulmonary artery. The float river discs were used with a very good outcome. And another case here of massive pulmonary embolism, you can see the pulmonary artery pressure measured at 78 millimeters of mercury, and after aspiration and removal of the clot, the pressure dropped down to 40 millimeters of mercury. The AngioVac device, we used it early on, the first and second generation devices. We realized that we're probably too rigid for the lungs. They have a very good indication for the Venacava, but the first generation devices were not as good for the lungs. Now we are getting the fourth generation and the AlphaVac device that is more flexible, smaller, 18 French, and is specifically designed for pulmonary embolism. The APEX study will start enrolling patients in a few months. And this is the way the AlphaVac works, with a manual handle, not requiring any more extracorporeal circuit. One of my first cases with the AngioVac back in 2012 or 13, going through the neck, you can see the AngioVac aspirating these large pieces of clot. But in general, we should keep in mind there is no single best device. Thrombolytic and non-thrombolytic techniques can actually be complementary depending on the case. Catheter interventions are not risk-free. You can still get major bleeds. You can still get stroke when you use lytics. No, it's not that frequent. And you can still have blood loss when you're using aspiration thrombectomy. Here on the left is an accidental cannulation of the coronary sinus. The patient was started on catheter thrombolytics and a little later bled with cardiac tamponade, required open heart surgery. On the right, the AngioVac device, very good final result with removal of clot, but this came at the cost of a rupture of the tricuspid valve. The patient required open heart surgery. This is our experience at the University of Pittsburgh. Early on, our clinical failure rate was 16%, but now following a learning curve, a technical learning curve, and a patient selection learning curve, clinical failure is down to 3% with a major bleeding of 0. But it's all a matter of having a multidisciplinary team, a PERT, and it's actually now down in the guidelines that institutions need to create these types of multidisciplinary teams for optimal outcomes. And some final remarks: catheter interventions are definitely here to stay, but we are likely seeing an unjustified increase in numbers. You can achieve faster clot removal and RV function recovery. You can prevent RV failure and decompensation. You potentially prevent pulmonary or long-term PE syndrome. These are not complication-free procedures, but complications are likely less than those of systemic lytics. Careful patient selection in high-volume centers with appropriate expertise within the PERT is essential for optimal outcomes. And with that, I thank you for your attention.
Thank you. Thank you, Makis. Thank you for that wonderful overview. Very nice, fantastic pictures you've shown us. Thank you for that great work that you do out there in Pittsburgh. Moving along now, we're going to be switching gears now and discussing the management of iliofemoral DVTs and what we have learned from randomized trials. And it's a distinct pleasure to welcome to the podium a pioneer of vascular medicine, Dr. Anthony Comerota, who has spent a majority of his life advancing the science and helping many scientists and clinicians along the way. So thank you for coming here today and joining us at the Vision meeting.
Well, thank you. It's really a privilege to be here. I thank Dr. Pappas and the program committee for the invitation. So I'm charged at looking at patients with iliofemoral DVT and what have randomized trials taught us, if anything, and these are my disclosures. Susan Kahn and her colleagues who have a deep embedded interest in post-thrombotic syndrome demonstrated to us in patients who have iliofemoral DVT treated with anticoagulation alone, they have the most severe post-thrombotic morbidity compared to lesser degrees of acute DVT. And you can see the odds ratio of 2.23, which puts the percentage of post-thrombotic syndrome a very high rate. And when we say, well, what exactly are we dealing with? I can show you what an occlusive iliofemoral DVT looks like because of this young woman who we became involved with 5 to 6 days after a big operation on her spine and for scoliosis. And she developed a classic phlegmasia cerulea dolens, and we couldn't give her catheter-directed thrombolysis because of the spine operation. So we operated on her and did a thrombectomy. You can see the thrombus beginning to extrude itself through that transverse venotomy in the common femoral vein. And because of the very high venous pressure, that continues to extrude itself. We didn't touch the vein at this point, but here you can see the thrombus burden, which is enormous in patients with occlusive iliofemoral deep venous thrombosis. And in her, we knew exactly when the clot started. So she was treated in the very acute phase, so there's no fibrous attachment to the vein wall. However, if this thrombus is not removed and if it's permitted to organize, it will result in what you see here on the bottom panel of the screen, which is well-organized collagen. And that is adherent to the vein wall. And when one tries to disobliterate it, you literally have to cut it away from the vein wall. This young woman was quite fortunate. She works as a hairdresser, so she's on her feet for about 8 to 10 hours a day. And this is her 3-year post-op photograph showing that indeed she's asymptomatic, has normal valve function, and no edema whatsoever. So I think a successful strategy of thrombus removal will prevent post-thrombotic morbidity. And we have 5 randomized trials. 3 of those randomized trials randomized catheter-directed thrombolysis plus anticoagulation versus anticoagulation alone. The Scandinavian trial, published by Gunnar Plata and colleagues, randomized operative thrombectomy plus anticoagulation versus anticoagulation alone, and demonstrated at 5 to 10 years follow-up that there was improved patency, lower venous pressures, less leg swelling, and fewer post-thrombotic symptoms in those patients operated compared to those patients who were not operated. El-Shawari and his colleagues used other endpoints, surrogate endpoints of patency and normal valve function, and demonstrated in patients randomized to lysis, there was significantly better patency of the iliofemoral venous system and significantly better valve function in those patients randomized to catheter-based techniques. Tuna Endon and her colleagues were the first to report a catheter-based therapy, catheter-directed thrombolysis through the drip catheter technique, plus anticoagulation versus anticoagulation alone for iliofemoral DVT. And they just wanted to know whether the addition of CDT was better than anticoagulation alone. And their primary endpoint was patency at 6 months and post-thrombotic syndrome at 24 months. That is any post-thrombotic syndrome. And that's the primary endpoint for each of the 3 randomized trials. I don't think that is a good endpoint at all. We can get into that in the discussion. And sorry for the overlay that occurred here on this slide, but basically what she showed was a significant improvement in patency of the iliofemoral venous system, and that translated into a significant reduction in any post-thrombotic syndrome at 24 months. And what they also found is that the number needed to treat to prevent one post-thrombotic syndrome at 2 years was 7, but because of the progressive nature of the post-thrombotic syndrome in the anticoagulated patients, which was not observed, no progression at 2 to 5 years in the CDT group, the number needed to treat dropped to 4 to prevent one post-thrombotic syndrome at 5 years. But what the KVENT trial did not show was any reduction in moderate or severe post-thrombotic syndrome. There was no reduction in pain and swelling, and there was no improvement in the quality of life. The KVENT trial, which was performed by our friends in the Netherlands, randomized 184 patients to ultrasound accelerated thrombolysis, and they used urokinase as the plasminogen activator, plus anticoagulation versus anticoagulation alone. And there was no difference in the endpoint, the primary endpoint, any post-thrombotic syndrome between the lysis group and the anticoagulation group. It's worth noting that 26% of the ultrasound accelerated thrombolysis group had their treatment discontinued at the 48-hour venogram because of inadequate lysis at 48 hours. And there was a significant cost of major bleeding, as you can see. And in those patients that were stented post-lysis, there was an unacceptably high in-stent rethrombosis rate of 13%. And just like the KVENT trial, the KVA trial did not show any reduction in moderate or severe post-thrombotic syndrome. There was no reduction in pain and swelling, and there's no benefit in terms of quality of life. And this brings us to the ATTRACT trial. Suresh Vedantam is an outstanding clinical investigator and a principal investigator for ATTRACT. This was an NIH-sponsored phase 3 trial, multi-center open label, randomized 692 patients with proximal DVT to anticoagulation versus anticoagulation plus pharmacomechanical, that's important, pharmacomechanical catheter-directed thrombolysis. Primary efficacy endpoint was any post-thrombotic syndrome. Again, not a good endpoint for this trials, and we'll get into that later. And then the tool that was used for the primary efficacy endpoint was the Villalta score, as it was in the other randomized trials. Secondary efficacy endpoint was looking at post-thrombotic syndrome with a venous clinical severity score, moderate and severe post-thrombotic syndrome, leg pain and swelling, and quality of life. There was no difference in post-thrombotic syndrome, any post-thrombotic syndrome, as you can see, and the major bleed rate went up from 0.3% with anticoagulation to 1.7%. I want to call your attention to the fact that these patients with symptomatic acute DVT were stratified at entry into the trial to iliofemoral versus femoral popliteal DVT. And after stratification, then they were randomized to their treatment group, CDT or anticoagulation alone. And that allows us to fairly look at these two groups independent of one another. And Clive Kieran and the other investigators that reported the outcome from femoral popliteal DVT in the ATTRACT trial demonstrated no signal at all of benefit from PCDT in patients with femoral popliteal deep venous thrombosis. But then we looked at the iliofemoral DVT subgroup in the ATTRACT trial, 391 patients randomized, as you can see, and looking at the Villalta score, there's no difference in iliofemoral DVT patients when we use the Villalta score as the tool. If we had chosen the venous clinical severity score as the tool for our evaluation of post-thrombotic syndrome, it would have been a positive trial for the primary endpoint because there was a significant reduction in post-thrombotic syndrome using the VCSS. I also want to call your attention to the fact that 14% of the patients with the iliofemoral DVT came into the trial with the normal Villalta score. So obviously we can't help them with catheter-based technique, and 33% in both groups had a very low, had a mild Villalta score, and I would argue that we can't help those patients either. And in clinical practice, those are patients that probably are not treated with catheter-based techniques. So here's two patients with iliofemoral DVT. You can see the one on your left, a young woman who has some mild symptoms, had non-occlusive thrombus in the fem-pop, but it extended into the common femoral, non-occlusive thrombus in the common femoral vein. That qualifies her as iliofemoral DVT, just like the person on the right who has a phlegmasia cerulea dolens, painful occlusive thrombus. So you have a non-occlusive clot and occlusive clot, and both of these were eligible for randomization for iliofemoral DVT. But in a patient with occlusive clot, this indeed was his phlebigram, showed extensive thrombosis of the iliofemoral system that opened up the deep venous return with catheter-based techniques. And you can see the May-Thurner anatomy with the blue, with the blue arrow there. And when that's corrected, there's unobstructed venous return to the vena cava. And at a 24-month follow-up, you can see he's doing very well, no edema, full activity, and basically is asymptomatic. So I think it's fair to say that not all iliofemoral DVT patients are the same. Well, let's look at these three trials in perspective in a head-to-head analysis. And you can see the KVENT trial for the primary endpoint was the only one of the three that met the primary endpoint. But look at what's below that, the secondary endpoints, which I think are much more clinically meaningful to patients. Moderate and severe post-thrombotic syndrome, pain, edema, quality of life. No difference in either the KVENT trial or KVUT trial. Significant difference in each one of those secondary outcomes in the ATTRACT trial. If we would have chosen the VCSS as the tool for post-thrombotic syndrome, we would have met the primary endpoint also. But let's look at the importance of technique. In the KVENT trial, the duration, the mean duration of infusion was 58 hours, 48 hours in KVA, 22 hours in ATTRACT. Significant reduction in the duration of thrombolysis. Look at the volume per hour that's infused. Only 18 to 25 cc's per hour in KVENT, 30 cc's per hour in KVA, 75 to 100, 3 to 4 times the volume per hour in ATTRACT. So if you think of the thrombus as a dried up sponge, and what you need to do is get that sponge sopping wet with the plasminogen activator solution to dissolve it, you're much more likely to achieve that outcome faster with a high volume infusion of and a low dose plasminogen activator infusion. And when we look at the dose, 48 hours of TPA, or 48 milligrams of TPA with KVENT, 5 million units of urokinase in the KVET trial, 22 milligrams, significant reduction in plasminogen activator in ATTRACT. And major bleeding was very low in ATTRACT, 1.5%, 3.5%, and 5% in the other two trials, as you can see. So technique matters. Increasing the surface area of the thrombus with physical manipulation. And we did that in ATTRACT with the trellis catheter and with the angiojet catheter, pulse spray, the plasminogen activator solution as a volume pulse spray going in. So that's perfusing the thrombus. High volume, low dose plasminogen activator infusion, precision of plasminogen activator delivery to the clot is very important, and that will improve efficacy and improve safety. So in the results, compared to no PCDT in ATTRACT, there was a reduction of any post-thrombotic syndrome using the VCSS score. There was a reduction in both moderate and severe post-thrombotic syndrome, a reduction in pain and swelling, and a significant improvement in the quality of life compared to controls within historically low risk of major bleeding. Once again, I want to thank you for your attention and thank you for the opportunity of being here.
That was incredible. Thank you again for taking the time to present all of that information. There's so much more questions I have, so we'll keep our questions till the end. But thank you so much, Dr. Comerota. Next, Vinay doesn't need any introduction, right? I mean, he's our resident, our shining star. And Vinay, I don't know if you know this, but you're the guy I call for all my complicated situations. So I just want to thank you personally for all you do. And he's going to present to us about vena cava interruption devices today, when to use them and how to retrieve them.
Thank you, Dr. Kelsey, for that kind introduction. Again, what an honor to be here today and be in a room of pioneers and continuing to push that vision along with the Center for Vein Restoration. In the next 8 to 10 minutes, we're running very much on time, I'm happy to say. So in the next 8 to 10, because we want to have enough time for questions and answers at the end. I want to just run through quickly the role of IVC filters, or cable interruption devices, and the removal techniques. And again, it's not going to be overly technical. It's just going to be an overall kind of sense of when you do send a patient and we need to remove them, how we do that. No disclosures relevant to this presentation. So why is this important? And we all know VTEs and PEs affect 1 to 2 individuals per 1,000. And with all the technology and all the advancements we have, it continues to be the leading cause of preventable death in the United States. It's alarming. 1 month mortality of PE, as Dr. Kelsey had mentioned, is twice that of DVT. And we have these wonderful anticoagulants out there that we're very well versed in. But unfortunately, IVC filters do not get enough attention. And when they do get the attention, it's typically negative. It's typically an advertisement you're seeing on TV late night about an ambulance chaser saying that, oh, do you have this device? You could be entitled to cash compensation, right? So IVC filters get this taboo about them. And when you start to talk to a patient about it, sometimes you can kind of see that fear of death come in them and say, you're not going to put that in me, are you? So IVC filters have been around since the first IVC filter was actually brought to science by Dr. Mobin Udin in 1969 and published some findings in the New England Journal of Medicine. These filters continue to advance, these permanent filters. The greenfield filter was utilized for many years. And the permanent filters, there's 2 types of filters. There's permanent filters and retrievable filters. The permanent ones have been around since the 70s, but as again, science advanced, these filters started to become retrievable. And as you can imagine, once they started to become retrievable in the late 90s, the utilization of them went exponentially up. Now, what are the indications for IVC filter? Again, IVC filters are helpful, but can be harmful, right? And IVC filters do not come without complications. Here you see on the right, this was a filter, unfortunately, that was placed in a patient with the thought of preventing a PE, and actually the filter thrombosed, as you can see those arrows, and basically has occluded the IVC. So filters do not come without complications. When we dive into the guidelines, there's 4 main societies that touch upon this. And these societies are the Society of Interventional Radiology, European Society of Cardiology, American Heart Association, and the ACCP. We're going to go through each guideline relatively quickly, but the point I want to make sure we all understand is that these guidelines, there's not a lot of overlap. There's some overlap, but some guidelines are not mentioning what other guidelines are saying. So there's still a little bit of hazy lucidness in this when it comes to this. On top of that, the data is limited to only really 2 randomized trials if you look into the literature. The first one was published in the New England Journal of Medicine in 1998. This was a study out of France. The acronym is PREPIC, which is Prevention du Risque de Emboli Pulmonary par Interruption Cave study. And what they did was they looked at 400 randomized patients that had an acute VTE event. And these patients were randomized into an anticoagulation alone group and an anticoagulation plus permanent IVC filter placement group. And as these patients were followed out over 8 years, the data interestingly showed that the patients that received IVC filters did have prevention of recurrence of PE, but it did not prevent death. And more so, more DVTs actually occurred in patients that received the filters. Expanding upon this data in 2015, PREPIC-2 study came out looking at, again, about 400 patients with PE associated with DVT. These patients were randomized again into the anticoagulation alone versus the anticoagulation, but this time it was with a retrievable IVC filter. These patients were deemed high-risk patients that needed to have at least one risk factor, as you can see here. Either they need to be elderly, above 75, have active cancer, a hypercoagulable state, have some degree of chronic cardiac or pulmonary disease, ischemic stroke with leg paralysis within 6 months, iliocaval or bilateral DVTs, or some sign of right ventricular strain or myocardial injury. Again, high-risk patients. What they found was that the retrievable IVC filter group did not show any mortality benefit, nor were there fewer symptomatic incidences of PE. Now, what do we do? So the question is, who benefits from an IVC filter? Well, let's go into the Society of Interventional Radiology guidelines and see what they say. They say the classic patient that qualifies for a filter, all of us pretty much can make sense of this, is absolute contraindication to anticoagulation, right? They have some type of risk factor, and those risk factors are defined there. Major bleeding diathesis, some type of coagulation defect, severe thrombocytopenia with a platelet count of less than 50,000, some type of uncontrolled bleeding, active bleeding, acute hemorrhagic stroke, severe uncontrolled hypertension, which increases the risk of hemorrhagic stroke, severe renal or hepatic dysfunction that can lead to, again, bleeding diatheses. Complications that arise from an anticoagulant, right? You put them on an anticoagulant with the good nature of wanting to help the patient, but unfortunately, it actually resulted in a complication. So you have to stop it, right? And finally, failure of anticoagulation. You had the patient adequately on anticoagulation. You felt that they were adequately, the levels were good, but the patient, despite that, still had a DVT or PE. That's failure of anticoagulation. Again, all sounds reasonable. What about the American Colleges of Chest Physicians? Well, very simply, they agreed. They say acute proximal DVT or PE, an IVC filter is reasonable, but only in those patients that have a high risk of bleeding with anticoagulation, right? What about American Heart Association? Now, this one is probably the most expanded indication, group that has provided indications. What they basically say is that, again, any patient that has an acute proximal DVT or PE, an IVC filter is reasonable if contraindication to anticoagulation or active bleeding. Again, that is all overlapping thus far. What they've gone on to further say is that if a retrievable IVC filter is placed, it needs to be evaluated periodically for retrieval, because the big problem is that these retrievable filters have been placed, but these patients have not been followed, and these filters then remain unnecessarily in patients. So the other thing that this society mentions is patients that have iliofemoral DVTs who are likely to require permanent IVC filtration, such as long-term anticoagulation. You can put permanent filters in them. But if you have a patient that you think that they're not going to need long-term anticoagulation, then do not put a permanent filter in these patients, put a retrievable one. So really important that they've mentioned that and in black and white. The European Society of Cardiology takes a very simple generic approach. They say, listen, it's indicated for two major reasons: documented VTE with a contraindication to anticoagulation, any of the contraindications we talked about, a recurrence of PE despite anticoagulation, again, failed anticoagulation, but it is not recommended for prophylaxis. Again, a very controversial topic. A lot of these retrievable filters have been placed prophylactically in patients. Now, again, the intent is good, but the question is, what does the data show? How do these patients do long-term? And unfortunately, as much digging as we do, there's just not a lot of data out there for these retrievable filters that are left in for prophylactic placement. Now, if you put the filter in, the filter should be taken out. So what about removal, right? We've put the filters in, we've gone very well versed in that. That can be done quite easily. It's the retrieval that can be quite technically challenging at times. Retrievable filters should be removed when the indication no longer exists. Sadly, studies show that only 8 to 10% of these filters that are placed that are retrievable are actually taken out. 8 to 10%. That is alarmingly low. So these retrievable filters do not have equivalent safety profiles when you compare them to permanent filters, right? They do not come without some potential consequence. What are those consequences? Caval wall penetration can occur. Unfortunately, as the strut makes its way into the wall, they can cause penetration and eventual weakening of the wall and perforation. Filter fracture. Again, the longer these filters stay in with all the tension and forces, they can fracture and eventually migrate and obviously cause bigger issues. And I showed you a picture earlier of caval thrombosis. Again, these filters over time can potentially cause a thrombosis and clot off. Now, filter retrieval techniques have been well employed and utilized and can be performed in an outpatient setting. We've, at the Center for Vascular Medicine have done some, but there can be difficulty and limitations with this. And again, we all have to understand going into this, we need to understand the anatomy. And so one of the key things to understand with filters is that they can tilt potentially to the left or right or, to the wall. And so as a filter tilts, it can become very difficult to catch the hook. And I'll show you a picture in a moment. Or the filter apex can actually get embedded into the wall of the vein, make it even more difficult to get to the top. Finally, these struts can become fibrosed. So you may be able to catch the filter, and as you're trying to pull it, it's tugging back on you because those struts have become fibrosed into the wall of the vein. What are the standard approaches? Typically, you want to perform a venogram before you pull the filter out. Now, IVUS, I think, is also very helpful here because you want to make sure you're assessing for any type of potential clog or thrombotic burden within the filter. Some centers actually do a CT abdomen and pelvis for filters that have been implanted long-term to just make sure that the anatomy is well defined. Then at that point, typical IJ access is obtained in a telescoping sheath, a 12-French sheath with an 8-French inner telescoping sheath is then introduced to the adjacent area of the filter, and then a snare is then taken into the hook. And I'll show you that in a moment here. If you can play that video, please, just click on that for us. Thank you. So you can actually see that that access there. You can see the snare hook at the top, and it's basically snaring. That snare is going into the hook, and what we're doing is we're with gentle traction, we're pulling on the snare as the sheath is being gently with contratraction pushed forward. So it's a telescope. So you're pulling out the filter as you're pushing the sheath forward, thereby bringing the filter into the sheath and then pulling the entire sheath out. Now, these standard techniques, again, they look very elegant and they work quite well, but as filters stay in for longer periods of time, these retrieval techniques can become quite difficult. And in the literature, typically greater than 7 months is when these filters can become technically challenging. Now, what happens if the filter hook or strut does get engaged into the wall? What do you do in that scenario? Well, for that, here's a picture of a tilt. You can see the filter has tilted to the wall, and not only has the filter tilted to the wall, but looks like the hook has become engaged into the wall of the vein. And so again, as you can imagine, if that snare is trying to come down and loop into that hook, it's not going to be able to do that. So what happens in this scenario? Well, this is called a wire loop and snare technique. And again, without getting overly technical, what you're doing here is you're taking a catheter and you're putting the catheter through one of the legs of the filter. In other words, you're cutting your losses short and saying, I'm not even going to try to get into the hook. I'm just going to put the wire through the leg of the filter, and then I'm going to fish the wire back up and create a loop. And then I'm going to try to pull the filter from the leg, with counter traction. Here you go. There's the loop that has been created. And so in this scenario, now you can see the filter has been untilted. So in some scenarios, once they become untilted, then they try to go, then the interventionist may try to go back in and then engage the hook again. So that's the wire loop and snare technique. There's a couple of off-label items that can be utilized. Obviously, if it's not coming out, and here you can see again that IVC filter is well embedded into the wall of the IVC there, endobronchial forceps can be utilized. And that's that picture with the arrow in the middle showing that those forceps are being, literally, you're trying to fish off the wall, that fibrotic wall off the hook, and tease and dissect it, and then try to pull that out through the sheath. The last off-label modality that could potentially be utilized is photochemical laser. As you're using a photoablative therapy here, laser, excimer laser can be used. And what the laser basically does is you take the laser to the wall where that filter, strut, whatever it may be fibrosed into the wall, and put the excimer laser on top of it and let that laser photoablate the area to kind of disengage it and decrease that fibrin. So in conclusion, IVC filters are important therapeutic options. There's no question about it, right? In management of select patients of VTE. But IVC filter indications have just not been studied with the same rigor as the application of anticoagulation. And while all professional societies that we've talked about support IVC filter in certain patient situations, they all kind of overlap with patients that have VTEs and contraindication to anticoagulation. And in summary, retrievable IVC filters should be followed and removed once the indication no longer exists. That's extremely important. And so with that, I thank you very much for your attention, and we'll continue along.
That was amazing. Thank you so much. Lots of questions again. It still baffles me that we don't have registries or something to track these patients to get these catheters back out.
Yeah,
you know,
exactly.
I mean, why? This seems like an easy fix.
Right.
Our next, we had a little program shift here. Our next speaker needs no introduction. I think all of us have heard him speak multiple times. Dr. Gasparis, if you could come up, please, to talk to us about what did we learn from the EVRA trial. And we apologize about your difficult trip today, but thank you for making it.
All right, so thank you very much for the invitation, Peter, Sanjeev. So really, in order to understand the EVRA trial, we need to kind of review the ESCAR. And prior to EVRA, ESCAR was really the only randomized trial looking at superficial venous treatment for ulcer healing. And the EVRA was really designed to answer some of the questions that ESCAR failed to answer, as well as some of the criticisms. So starting off with ESCAR, really in 2004, this was a prospective randomized trial, really looking at high ligation back then and stripping with phlebectomy plus compression compared to compression alone. And this included about 500 patients. 300 of them or 60% had isolated superficial disease. About 40% had both combined superficial and deep reflux. So these were patients with all active ulcers. The endpoints was healing at 24 weeks and recurrence at 12 months. So this is the design, and you can see there was about 1,400+ patients that were screened, leading to about 500 patients that were randomized. And you can see there the breakdown. Now, when you look at ulcer healing in compression versus surgery, you can see pretty parallel curves there. At 24 weeks, the ulcer healing rate was 65% in both groups. So really, compression plus surgery didn't show an advantage when you compare it to compression alone. And that was really no difference out to 3 years, with about 89% healing in the compression group and 93% in the group with surgery. But when it came down to ulcer recurrence, you can see there the curves are kind of spreading apart. And 12-month freedom from recurrence was significantly lower in the surgical group, 12% compared to 28% in those who underwent compression alone. And that was maintained out to 4 years with a significant lower recurrence in the surgical group. So when you look at this, really surgical correction of superficial disease in addition to compression bandages did not really affect ulcer healing, but it did reduce the recurrence rate and also the freedom from ulcer time in patients who underwent surgery. Now, several criticisms in this trial, really it was comparing surgery to compression with compression versus compression alone, but the surgical group had a median time of 7 weeks prior to undergoing operation. So there was an inherent bias for the ulcer patients to do better. Both groups had compression, so ideally you would want to possibly compare surgery to compression alone. There was a good number of patients, 40%, that had both superficial and deep disease. The ulcers were small. The average size was about 2 centimeters, and there was a good number of patients, a quarter of them, that refused surgery. Finally, compliance was really not assessed in either arm. So ESCAR showed overall reduced rate of ulcer recurrence and early treatment, and the effect of early treatment of reflux on ulcer healing remained unclear at this point. So this is where EVRA came about. And really the goal of EVRA was to see if, if we should be treating these patients early on and not wait until the ulcer heals. So this was a multi-center trial, and it looked at, early intervention compared to deferred intervention. Both arms, again, did receive compression. So the primary endpoint was time to ulcer healing, and this is the list of secondary endpoints that were looked at. Interestingly, compared to the ESCAR, where there was about 1,500 patients, here 6,500 patients were randomized. And the size of the ulcers were similar to the ESCAR. They were small and pretty early. The average time of ulcer was about 3 months. This is the breakdown again. And when you look at the demographics of the two groups, similar age, a little bit older population, ulcer patients, BMI elevated in both groups and similar. And the size of the ulcer was pretty close to the same. When you look at time to intervention in each arm, so the early intervention, you can see 95% of the patients were treated within the first month, whereas the delayed group, over 95% of the patients were really treated 4 weeks or more, and a third of them 6 months or more after randomization. As far as treatment, so this is one of the criticisms that's discussed in the paper, is basically endothermal ablation alone was offered in about 20% in one arm, 24% in one arm, 30% in the other arm. So there was really not comprehensive treatment of the superficial disease. Half of the patients in each arm had sclerotherapy alone, and only about 10% of the patients had both treatment of the saphenous and the varicosities. So when you look at time to ulcer healing, you can see it was significantly less in patients who underwent early intervention compared to those who were deferred. And there were more patients that were healed out at 12 weeks in those who were treated early. So overall, in the whole group, about 90% of the ulcers healed within 1 year. It's kind of similar to the numbers in ESCAR. And the recurrence rate was around 10 to 15%. And that was not any different in the two arms. And again, the recurrence was at 1 year, similar to the numbers in the ESCAR trial. When you look at median ulcer-free time at 1 year, though, the time of free ulcers was higher in those patients who were treated early compared to those who it was deferred therapy. So in summary, early venous ablation and superficial reflux treatment resulted in faster healing in venous leg ulcers, more time for free from ulcer, but the limitations are similar, or some of them are similar from the ESCAR. The small ulcers, short duration. There's variable treatment modality, as you saw from there, and in some situations, most of the situations, there was no comprehensive treatment. When you look at long-term follow-up, this is the second paper that was published in 2020. You can see the early intervention group had a significantly lower cumulative recurrence rate compared to the deferred group. And the authors concluded that it's highly likely that this would be cost-effective to manage patients with early intervention for venous ulcers. So ESCAR really did not show that intervention actually is superior to compression. So there's really ulcer healing is similar regardless whether you compress the patient or you ablate them. But it did improve ulcer recurrence compared to compression alone. And EVRA showed us that if you intervene early enough in these patients, that you can increase increase their ulcer-free time, and time to healing is much faster. And with that, I would conclude. Thank
So much.
Very nice. Excellent job, Dr. Gasparis. Thank you very much. And please join us on the podium.
What about Dr. Comerota? Does he want to come back?
Yes, and please, Dr. Comerota, please join us on the podium as well. At this time, we're going to open it up for a panel discussion. And, once again, this is about all of us learning together and sharing any thoughts. And so please feel free to ask any questions or share any experiences that you may have. I am going to kick it off by asking a very, very elemental question. I'm going to ask Dr. Kelsey something. So you talked very nicely about the approach to CAF DVTs, right? And how these patients should be managed. But, as you do, thousands of these non-thermal, non-tumescent modalities, unfortunately, you do enough of these, you'll start to see tibial vein DVTs. And I was just curious as to how do you approach a patient that has a complication like that tibial vein DVT after a varicose, for example, or even radiofrequency for that matter, in this particular group? Do you approach it the same way, or do you have any type of tips or tricks?
So I approach it the same way. I try to look at why did this happen in this person? What were the predisposing factors that led them to this outcome? So do they have a malignancy? Are they elderly? Are they not mobile? Is it a transient thing? Is it just from me doing an ultrasound guided procedure, or is there more to the story? I usually observe them, and I will do, I'll stop treatment and do serial ultrasounds. And after that 10-day window, I'll call it good. And then we'll reassess it at 1 month. Some patients where I feel that I'm just uncomfortable based on how close it is to the popliteal, how extensive it is, the risk factors, I will give them a Xarelto starter pack.
Okay.
And when we see them back at the 1 month follow-up, we usually see that clot is reabsorbed at that 1 month follow-up. So what I'm interested in seeing is how the DOACs will help or change the way we manage some of those things. So.
Yeah. So they do behave differently in your experience.
Yeah, I don't see them propagate ever. I mean,
Yeah.
Sean just mentioned that too. You're probably more conservative. You probably watch more too.
Yeah. Got it. Thank you. Dr. Gasparis, anything to add?
No, I think Peter has it.
Yes, I have one question for Dr. Comerota and another one for Dr. Avgerinos. So Tony, you mentioned the technique matters. And one of the things that popped out to me in all of the studies is that all of them indicated that there was some residual thrombus that was left behind. So to what degree do you think some of that residual thrombus affected the outcomes of the study? And Makis, for you, where do you see us going in terms of pulmonary embolism, in terms of these technologies? Do you think it's going to be any better than anticoagulation, or the more you look into this, it seems like anticoagulation seems to be the way to go, except in the people who have like massive PE with hypertension? So Dr. Comerota, if you would go first.
Sure. Very, very good questions. Yes, I think residual thrombus does play a role, and the more clot we can remove, the better the patients are going to be. There's some very interesting facts that many of us are not aware of. 30% of the patients who develop a proximal deep venous thrombosis have valvular incompetence before they clot. Now, I say that knowing that we don't study them before we clot, but they have valvular incompetence of their deep venous system in the contralateral leg. And we studied that and reported it. We also did a prospective study of patients coming in, referred to our vascular laboratory for signs and symptoms consistent with acute DVT, i.e. pain and swelling. We all know that a large number of those patients do not have DVT. Their venous duplex is negative. In that group, in symptomatic patients in whom the duplex was negative, the valvular function in the contralateral leg and the ipsilateral leg was about 9% valvular dysfunction. In the patients who had acute DVT, their their valvular dysfunction rate was around 32% in the contralateral leg. So I think that's real, and hence that these patients, a large percentage of these patients are coming in with valvular dysfunction. And I rather think that if we did a Villalta score the day before their acute DVT, it may well be 5 or more, 5, 6. That's mild. But that was the primary endpoint for the 3 catheter-based studies. And that's why I say that it's probably not a good primary endpoint for studies such as this. Moderate and severe post-thrombotic syndrome, I think, is much more important.
Makis, are you still there?
Yes, yes. So there is little doubt, Peter, that we are seeing an overutilization of these techniques. Everybody has started sticking a catheter in the lungs for pulmonary thrombolysis or pulmonary thrombectomy, and there is little doubt that it can help in massive pulmonary embolism, but there is a big question mark for submassive pulmonary embolism. And I know we have been trying for years to start the NIH trial, the PE tract, and it's still not starting. So till then, we don't really have good data. Now, based on my experience and what I see, I think there is definitely a subgroup of patients with submassive pulmonary embolism that will benefit. These are the patients who have positive biomarkers, have positive echocardiographic markers, but this, again, is not enough. You need to have at least 5 or 6 liters of oxygen requirement. You need to have a heart rate of more than 110 and a soft blood pressure. Only focusing in this population, I think we're going to see a benefit. It's going to be something similar with the ATTRACT trial. If we start enrolling all patients with submassive pulmonary embolism, we may not see a benefit. But if we focus in a population equivalent to the iliofemoral thrombosis group, we will probably see a benefit. And we should work towards that direction. I can tell you that 4 or 5 years ago at UPMC, we have been doing 100 cases per year. Right now, we are doing 30 to 35 cases per year because we've seen this doesn't work always and we get complications.
Tony, quick question. You mentioned about the issue with Villalta being an outcome measure, and talk about PE. What are we going to look for as an outcome? But the problem you're talking about with patients having an underlying previous event, whether previous DVT, and have a score of some sort, whether it's VCSS, Villalta, whatever it is, that problem you're going to have with any outcome you're looking at, right? I mean, they may have, in the study, it showed a significant improvement in VCSS, but maybe their VCSS was low to start with and from a previous event. So unfortunately, because DVT recurrence is significant, 50% at 10 years, a lot of these patients that are being treated may have had a previous event that never even knew about. Mm-hmm. So how can we tell, what is the best way to really show that you're preventing these patients from getting worse after their most recent event?
Well, number one, I think moderate and severe post-thrombotic syndrome, as opposed to mild, will answer the important question of the benefit of catheter-based therapies or strategies of thrombus removal, whatever that strategy is, and compared to anticoagulation alone. And for pulmonary emboli, just to supplement the comments of Makis, I'll call your attention to what I think is a very good paper by Sekemsky and colleagues from the Mass General that was published, 3 or 4 years ago. And what they did was, and they wanted to answer the question whether advanced therapies were helpful in patients with massive and submassive PE. What they did is they looked at 90-day, and I think 90-day mortality is a more appropriate time point to answer that question than 30-day mortality, because there's so much carryover. And what they found was in patients who received anticoagulation alone for massive, and this was a large multi-year observational period, the mortality for massive PE was 60% at 90 days, and it was 16% at 90 days for submassive PE in the patients who received anticoagulation. If you look at the patients who received, they termed advanced therapies, that could be systemic thrombolysis, it could be catheter-based thrombolysis, it could be mechanical thrombectomy, advanced therapies. The mortality rate dropped by 50% in the massive PE, and it dropped by 75% down to 4% at 90 days for submassive PE. Observational studies, but it came from a really good group, and I think that was the stimulus for them to develop the PERT team when they analyzed that data.
Very good. Anybody else have any other questions or comments?
Dr. Comerota, I have a question too. We talk about the patency, but in those trials, I didn't see a lot of publication about concurrent venous insufficiency. And in the studies that I was looking at, the post-thrombotic rate, when you separate that, the superficial venous component out, the actual post-thrombotic syndrome was much reduced, like from 30% to 15%. So how did these trials
You're talking
address that?
about catheter
Yeah,
thrombosis.
yeah. So how, but in, I mean, there's a lot of overlap there. So how in the ATTRACT trial did they account for just superficial venous disease and the role that that might
Who
play?
didn't?
Do you think that would be a differentiator in any of those patients?
Oh, I think you would probably see some worse outcomes in people with documented valvular incompetence in the superficial system. Sure, I would think so. We just didn't do it.
I see.
Sounds like a study for CVR.
Right.
All right. Anything else, Dr. Kelsey? Please.
The only other question I have is when would it be too late to refer somebody to get a removable, retrievable filter out? Like at what point do you just say, let's just leave that thing alone?
Yeah, so 7 months is like the gold standard number, but these filters can be retrieved up to 2 years out. Obviously, keeping in mind that as these filters are in longer, they're going to be more technically challenging. Dr. Gasparis?
It also depends on the type of filter. Like the selects or some of the barred filters are, you can take them out easier farther out. The tulips tend to be a little bit more embedded early on and are not as easy to take out. But really, I mean, you can take them out 10 years, they've reported out.
Oh, really?
10 years, 20 years. I mean,
Yeah.
with advanced techniques, with laser and stuff. So
Yeah. That makes sense. I mean, you can use the excimer laser then to decrease that that connective tissue there and be a little bit more aggressive. So we'll send them to Stony Brook.
sure.
All right. Well, thank you, everybody. Let's go ahead and take a break.